Wednesday, and that means it's time for us to delve into medical matters. Our resident GP is Dr. Vicky Skitter.
Hi everyone, it is Wednesday and it is the medical show on Mansfield today. I'm flying solo, which is a bit stressful, but here I am. We are talking eyes today. So we are going to have a chat with Dr. Neuner. He's an ophthalmologist at Fourways Life Hospital, and he's been so kind to chat with us. Hello, Dr. Dory.
Hi, Dr. Vicky, how are you?
I'm fine, and you?
Good, good. Nice to be back.
Yeah, it's nice to have you back.
Pity Jeremy isn't with us.
He ran away. Anyway, I thought we can maybe talk about something that I see quite often in my practice. I don't treat it because I can't, but it's cataracts and glaucoma. So
it's two very common conditions.
Yeah, you see that all the time. So can you tell us what a cataract actually is?
Sure. And I'm actually going to just swap to a model of the eye. So if you think about the eye, it works like a camera. And just like a camera, there's a lens which focuses what you're looking at onto the back of the eye, the retina, which is like the film or the sensor of a camera. Now, when we say someone has a cataract, we mean that the lens is going cloudy. And cataracts normally happen to all of us as we age. And as the lens gets cloudier, because your lens is not clear, you can't focus clearly, so your vision goes blurry. And the treatment to fix a cataract is to actually replace that lens. So we take out the cloudy lens and we pop an artificial lens, a clear lens, in its place. That, in a nutshell, is what a cataract is. It's a clouding of the lens in your eye.
Can you prevent cataracts at all?
So the main reason for a cataract to occur is age, and it's got to do with our UV exposure over the years. So that's why most people get them in their 60s and 70s because of chronic UV exposure, and people in sort of high UV countries will get them in the early 60s as opposed to people in, let's say, Europe. Low UV exposure sort of more in towards their 70s and 80s. So yes, UV protection does delay the onset. Like we see people with game rangers, cricketers, people who spend a lot of time outdoors get them sort of a lot earlier than sort of other people. So a good pair of UV protective sunglasses is something that everyone can do to sort of prevent, not prevent, you can't prevent them, but you can sort of delay them.
Delay them. And do young people ever get cataracts? Have you seen that?
Sure. Yes, absolutely. You can be born with cataracts. So there are different reasons to get cataracts. Young people would get cataracts either because of a familial, a genetic, a gene or genetic or what we call congenital cataract. So it's in the family, parents have had them, other siblings have had them, and the child can be born with it. If the mom had certain viral infections during her pregnancy, then that can lead to the baby being born with cataracts. We can see cataracts in young people from trauma to the eye, anyone who's been on steroids, cortisone for a long period of time, or poorly controlled diabetics, probably the most common reason for a young person to get cataract.
Okay, so now you said you just replaced the lens. Does everybody need surgery? I suppose.
If you have a so yes, so if we go back to that model, so if your cataract is affecting your vision, that's the thing. Just because you have a cataract doesn't mean that you need surgery. In time, as the cataract develops, it will blur your vision. And it's only when your vision is affected, then you need surgery. So everyone, inevitably, if they live long enough, will need surgery to replace that lens.
Okay.
Or if it's only when the vision is actually affected. So you can see someone with a cataract. I might see the cataract and tell him he's got a cataract. But if he says to me, well, my vision's great, and I agree, then we can watch it until it gets worse.
Now, my next question, is it common to have only one cataract? Do they often have cataracts on both eyes? And can you operate on both eyes at the same time?
So if we're talking sort of the normal age-related cataract, it happens in both eyes. It can be asymmetrical, where you've got one eye that's affected very early and the other eye that can happen years later. But in general, once your vision's affected in one eye, it's affected in both. And you will have surgery in both, but not at the same time. So because it's surgery, the convention is do one eye and then a week later do the other eye if everything goes well, as long as the patient's happy and the surgeon's happy that everything is going according to plan. Sometimes you do both eyes at the same time, especially if it's a patient who maybe needs a general anesthetic, which is not what we normally do for cataract surgery.
Okay.
Or if it's sometime with sort of mental illness or someone with mental illness or something like that, where you want to get it over and done with very quickly so that you don't have to bring the patient in and out of hospital or in and out of theatre. But the convention is to do one eye at a time.
Okay, now when they open the eye or when they, I don't know, when you've replaced the lens, can they see properly immediately? How long is the recovery after surgery?
Very quick. So you can actually, you can see pretty much straight away. It's not very clear on the first day. The next day, when the patients come for their checkup, their vision often is brilliant and a lot better than what it was before. And then you kind of just carry on with your life, and you've got eye drops to use for about 3 to 4 weeks post-surgery, but in that time, you can see very well. So the results are, instantaneous.
And you can't get a cataract again, hey, because you've got a...
No, you can't, because you've replaced the lens. But you can, but you'll hear patients saying, my cataracts have grown back.
Oh,
but it's not that.
Yes.
What actually happens is that, I'll just go back to my model to show you, but so we implant the lens into this capsule and you get scar tissue developing on that capsule, which can blur your vision a few years after the surgery, and that patients feel like their cataracts are coming back, but that can be treated with a quick laser procedure in the rooms and then it's gone.
Okay, clever. Okay, so that's cataract. So glaucoma, what, is it common? I think so.
Well, so glaucoma, just to sort of understand what it is a disease of pressure in the eye. So your eyeball, if you think of an eyeball as like a balloon full of water, and there's a pump that's pumping the water in, and there's a filter that's filtering the water out. And that regulates the pressure in the eye. So it's not related to blood pressure or stress or anything like that. The eye has a pressure which it's comfortable with. And when someone has glaucoma, most patients who have glaucoma will have, it means that their pressure is now higher than what their eye can tolerate. And that damages the nerve. And it's a very slow disease. And in time, as the nerve gets damaged, you start to lose your vision. So patients will start to lose, will start to lose their peripheral vision very slowly. And if you don't treat it over time, you end up with what's called tunnel vision. So you never want to get to that point if you can avoid it. You want to, often when the vision loss is just a little bit on the periphery, the patient won't know it. So you want to pick up patients as early as possible, which is...
So this is how you'll pick it up at a normal eye check, hey? They check the pressures.
Exactly. So you'll normally either come to an ophthalmologist, or your optometrist will pick up high pressures and send you to the ophthalmologist to be assessed. Now, the reason for the high pressure is as I said, your eyeball is like a balloon full of water or a ball full of water, and the pump is pumping fluid in, and the filter is filtering fluid out. And the filter is situated in this area of the eye, what's called the angle. It looks like a sieve, and it filters the fluid out into a little drainage canal. Now, often what happens is it's this filter that gets blocked or that doesn't filter properly. So the pump is still pumping the fluid in, but the filter can't keep up, and so the pressure increases in the eye. And the most common type of glaucoma, what we call open angle glaucoma, is related to a malfunction here.
Okay, sure. All right, so now we've seen how it develops. So basically it causes permanent damage to the optic nerve. Is that what you're saying?
Irreversible damage. If you don't pick it up in time, you can never bring back the vision that's lost.
Okay.
So the aim is to pick it up early and to keep treating it and to keep following up with your patients to make sure that they're under control, that they're not losing vision.
Okay, so now I often see patients and I have to repeat their eye drop scripts. That's about all I have to do. How do the drops work? What does it do? How do you
So
treat
the drops aid. So the main treatment, or the mainstay of treatment, is to use eye drops, which become like chronic medicine. You use the eye drops every day for the rest of your life, and the drops lower the pressure in the eye either by slowing down the production of the fluid or by aiding that fluid in filtering out of the eye. And that's why the pressure in the eye drops from the high level that it was to a lower level. And and patients need to follow up every 6 months in order to make sure that, first of all, the pressure is low enough that despite your efforts, you have the pressure low enough using the eye drops so that they're not losing more vision, so there's not more nerve damage.
Of course.
And we pick that up on testing every 6 months. Sometimes you've got a patient on treatment and they start to become tolerant to the treatment, the drops. And then you have to change the drops or add more drops in order to keep their pressure low. But drops aren't the only way to treat glaucoma. We can treat it with laser treatments, which you can either use it as an alternative to drops sometimes or just as an addition. So instead of giving patient 2 bottles to use, you can keep them on their same bottle and then do a laser treatment.
Okay.
And there's newer techniques, what we call minimally invasive glaucoma surgery, which involves implanting tiny little, what we call stents. They look like stents, they're little tubes, into the eye during a cataract procedure. The stent is implanted, if we go back to the model, into this filter and actually creates, it's like a little hole, creates a little tube, a passage for the fluid to drain from the eye and keeps the pressure low. So we've got these are the newer techniques. We've had them for a few years now and they work really well in getting patients off their drops and also reducing their pressure if they're not well controlled on their drops alone.
Okay, so almost like putting a grommet into your ear, sort of.
It's very similar to a grommet, but tinier, much smaller.
Okay, much smaller. So now, can you cure the disease, or is that what you actually said? If you put the stent in, you've cured it.
Yeah, you can't. So cure is a strong word because cure would mean that the patient doesn't have to sort of ever return for sort of follow up. So sometimes the stents, yes, they can cure you from a point of view that you don't need your drops anymore because the pressure in your eye is now low, but you still need the follow-up because things can change. And the problem with glaucoma, it's the silent thief of sight.
Okay.
Patients don't know when their pressures are up. They can't feel it. You can't feel it. And so you don't know if you're losing vision, which is why even after sort of successful surgery and no drops, or even if someone's well controlled, we still need that constant follow-up to make sure that things remain the same because the vision loss is irreversible. So you never want to get to that point where now a patient has lost sight and there's nothing you can do.
I like that, the silent thief of sight. Sure, it's true. Dr. Dory, thank you so much for this insightful, pretty pictures that you showed us.
Thank you.
I've even learned a lot. Thank you very much for your time.
Thanks a lot, Dr. Vicky. We'll see you again.
Okay. Thanks, Dr. Dory. Bye. And I suppose this is the end of my show. Bye.